Right. Good evening. Yeah, I think I'm seeing you after 2 weeks. Hope you all are fine and safe, right? So we be aware about this COVID now. As we know, now the country is not in a good condition, right? So everywhere is corona. Even pregnant mothers are getting corona, and we are delivering a lot of pregnant mothers, COVID pregnant mothers. So we all are busy, and of course you all have to be safe, right? And the very sad news is because of the COVID, people are struggling. Not only that, of course, the CRPF students also getting uh, you also getting delayed for your exam, right? So we don't know the exact exam date. Anyhow, you keep on study. So that's why I just want to keep you in touch with the obs and gynae. So then I'm continuously doing few uh, papers, free papers, as well as I'm doing like yes, we have done already 4 free papers. So that this time I thought we will discuss, because for a long time we didn't touch any theory session. So I thought to uh, mix up with this theory and the MCQ. So then actually today I thought to do like we'll discuss one theory topic along with we will discuss some MCQ and SBA related to that theory, right? So today we are going to discuss about the PCOS. So then why I think about the PCOS, because if you see the clinical scenario, right? So when I'm going to the clinicals of like gynecology clinic, so roughly 40% of patients are coming with PCOS, right? So even the fertility clinic, we are encountering a lot of patients with PCOS, right? So what is PCOS? First of all, you need to know that, right? So anyhow, I will explain everything to you. So anyhow, the amount of PCOS patients are increasing nowadays. So we are encountering a lot of patients with PCOS. So uh, and not only your clinical practice, also for the exam, right? If you see your MCQs, right? So SPA having a lot of PCOS questions. And when you go to the clinicals, right? So patients are presenting with menstrual irregularity, oligomenorrhea, right? No worries. We will discuss what is it. So there might be very juniors. So you don't need to worry about these terminologies. I'll explain each and everything. So a lot of patients with menstrual irregularities. You are getting long case discussion for with menstrual irregularity, and PCOS has impact on your reproductive, right? So they are presenting with subfertility, right? So subfertile case complicated. 90% of anovulatory subfertility is due to PCOS, right? So again, you are encountering with a PCOS patient in subfertility. Again, even when they are becoming pregnant, of course, they are having a lot of complications like miscarriage, gestational diabetes mellitus, right? So there are so many complications. So actually speaking, this PCOS has impact in a reproductive woman since menarche to menopause, even not only the menopause, even after the menopause. Do you understand? So it is an emerging problem to the young generation, right? So not only giving an age to you, not only making you to pass, not only uh, uh, make you to understand the stuff, manage the patients when you become as a clinician. Also, roughly 40%. Actually, we don't have actual value, but roughly 40% of girls are PCOS, right? So among you, so there are so many girls in my class. So a lot of girls might be PCOS. The boys, your girlfriend might have PCOS. So during this class, and understanding about the PCOS will help you to improve your health condition. It will help you to advise your friends to how to overcome this PCOS and related complication. It will help you to advise your patients, your neighbors, relatives, and of course, ultimate target is you will be a good clinician encountering this PCOS, as well as you can simply pass the exam. So that's why I thought to do this PCOS class today, because it is an emerging problem. Of course, you all should know about this PCOS problem, right? So we will discuss the coming 2 hours. So we are going to discuss about the PCOS. And finally, we'll discuss the MCQs. Okay, just tell me, what is PCOS? So I'm telling repeatedly, I'm telling PCOS, 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 PCOS. So what is PCOS? First of all, you need to know what is PCOS. PCOS is polycystic, or actually the name is polycystic ovarian syndrome, right? So PCOS is polycystic ovarian syndrome. So I will teach you why we are saying as a polycystic ovarian syndrome. What is the difference between polycystic ovary and polycystic ovarian syndrome? So if anybody knows, so I would like some students to interact my class actually, because even though whether it's a paid class, whether it's a free class, doesn't matter. If you all are interrupting, so then it will be more interactive session. So please, so if somebody can answer, so then it will be a very interesting session. Otherwise, I don't like to do like a presentation based lectures, but of course I'm going to show you few feature photos and pictures with presentation, but it should be a interactive session. So what is polycystic? Okay, just tell me, polycystic ovaries, one condition. Second one is polycystic ovarian syndrome. What do you think? Both are same, so both are different? What do you think? Same or different? Polycystic ovary, polycystic ovarian syndrome. Very good. So both are different, right? Both are different. Polycystic ovary means it is a condition where the ovaries, as we know, the ovary has a lot of primordial follicles which are stored in your ovary. So these primordial follicles got arrested and there will be a lot of small cysts. What is cyst? Cyst is a fluid-filled cavity. Cyst is a fluid-filled cavity. So when you see through the ultrasound scan, right, you can see like a black color spots. So if it is an ovary, actually, yeah, I will show you. If you see the ovary, right around the ovary, you can see some hypodense area, blackish lesion like this. What is this? This is a small fluid-filled cavities. This is called cyst. So when you have multiple cysts, that is called polycyst. So when you see this ovary, actually this ovary has multiple cysts. That's why we call it as polycystic ovary. So what is polycystic ovary? Actually, it is a condition where the ovary has multiple follicles, multiple cystic lesions, right? But the polycystic ovary and polycystic ovarian syndrome, both are different. Polycystic ovary is a condition where the fluid-filled cavities, a cyst, multiple cysts present in the ovary. But polycystic ovarian syndrome is a collection of metabolic and ovarian dysfunction. It is a condition where you are having so many factors, so many metabolic disorders involved, right? So polycystic, sometimes some girls might have polycystic ovary, but they are not having rest of the metabolic disorders. Sometimes these girls might have these metabolic disorders, still they don't have a polycystic, but they are polycystic ovarian syndrome. It means this polycystic ovarian syndrome not only depend on this polycystic appearance of the ovary, also it is involved with the other metabolic, collective metabolic syndrome. There are so many things we will discuss. Do you all understand? So polycystic ovarian syndrome is a complex condition where your ovarian abnormalities and your metabolic abnormalities, and a lot of things are connected. So when I'm telling why I'm spending time to explain this polycystic ovary and rest of the metabolic syndrome, right? So first of all, you need to understand what is the connection between this polycystic ovary as well as this metabolic derangement. So what could be the reason why there are polycystic ovary, why there are metabolic derangement? So if you see this polycystic ovarian syndrome, right? If you see your polycystic ovarian syndrome, here this polycystic appearance means the inability to develop or failure to develop the follicle as well as the metabolic derangement is basically from the same pathophysiology. Right? Same reason. So the basic pathophysiology is same. So when you study the obs-gynae, not only obs-gynae, also the other subject, right? To have some idea or to understand the subject properly, always keep it in your mind. You need to understand from the pathophysiology, from the very basic things, because without knowing the basic building block, right? Without knowing the basic material, you can't build a big house, big palace. So you have to go from the root. What is it? So when you are going to study about the PCOS, first of all, you need to know what is PCOS. So always you have to ask question to you again, right? Again and again. What is polycystic? What is the difference between polycystic ovary and polycystic syndrome? Why it is happening? What could be the risk factors? Why they are developing? So if somebody have polycystic ovarian syndrome, what could be the consequences? What are the problem might comes? So how do I know whether she is having polycystic ovary or not? So if I know what I am going to do it, so you have to make question, right? So if you know the basic pathophysiology, right? So first of all, if you know what is polycystic ovarian syndrome, second, if you know why it is happening, what is the reason for the development of polycystic ovarian syndrome, then you can easily identify the risk factors, because these are the changes occur in the reproductive woman. That's why she is developing all these complications. So why these changes occur? What could be the risk factors? You can work out. So then if it is developing like this, what are the derangement might occur? So once you identify the derangement, how to identify that derangement? So if you know that basic, actually you can simply develop your rest of the part. So if it is occurring like this, what will be the consequence? You can simply think like, if it is an oligomenorrhea, if follicles are not developing, obviously without developing the egg, can you have menstrual bleeding? No. So then the woman will not have regular period. Without egg, can you have baby? No. So then if they can't produce the baby, how do you call that? That is called subfertility. So you can just think about the complication if you know the basic stuff. So always you have to spend the time for your pathophysiology. Then only you can understand, yeah, this is the basic explanation for this disease. So then if somebody has this problem, these are the consequences might occur. So then how to identify? Okay, and you know, of course, this is occur because of this. So then if I want to stop this basic one, what I'm going to do? That is your management. So always you need to have this picture. Always you need to ask questions for you. Yes, why it is, right? So some students might know about my classes. Some students are very new to these classes. So if it is new, right? So when you come to the theory class, then you will realize how. Because most of my students, when they are coming, they have less understanding. They studied obs-gynae, but they don't understand the obs-gynae. That's why they feel like very difficult. But once you understand the basic, so no point in teaching in a superficial manner, because finally you can't remember each and everything. But once you identify the basic stuff, right? So then it's easy, because we have proof with your seniors. once we understand what will be the outcome, we have proved, right? So throughout this ERPM career, the pass rate of Genanops was just 30%. But last time, what was my students' pass rate? It was 90%. What is the reason? Because all of my students know the basic. So increasing the pass rate from 30 to 90, it's not a simple task. I didn't do much thing. What I did is I just helped my students to understand the subject. This is how the subject. They understood. Finally, they passed. So I'm waiting for the Viva results, because this time Viva also more than 90%, because all the students gave very nice feedback to me. They have done marvelous. Most of the examiners ask, who is your Genanops teacher? You are answering like a postgraduate candidate. So really, that is the only one they made me proud. Right? Really, they made me proud, because when the examiners ask, who is your teacher? What else you can give it to me? Really happy moment. You know, you all have to understand the subject, and you need to perform well, not only in the exam, also in your career. Once you become the way you are working, the way you are interpreting the patient, way you are taking the history, the way you are thinking about the next step, right? So we'll give the respect among the other staff. Because when you come to the internship, you can't get scolded by the consultant in front of nurses, in front of other minor staff. You should have a background knowledge. You have to keep your dignity. So that's why I'm always teaching the stuff with the students, to the students with the clinical background. Always you need to know the clinical background. Why I'm studying, how the patient will present to you. Right? So if you want, you can have a chat with your seniors. So the part we have discussed for the Viva, I have asked those questions. So nothing they ask new things. Everything they ask what we have discussed in the case discussion as well as Viva class. So it means you need to understand, right? So what is the importance of knowing the background knowledge and the way of thinking? Always I'm telling one word. What is the thinking? Rational thinking. You can't be like a robot. You should have a rational thinking knowledge. You have to think rationally. When you come to the paper class, you will realize it, right? So no worry about that. So more than that, I want to help my students. So I'm giving a platform for you with multiple facilities to you. So probably it will be available from August 20th. So it is going to be 24/7, right? So once you join to my class, until the platform available, maybe until you retire, you will get the free access for the recorded classes. And also you will get a unlimited live class access. Everything is automated, right? And there are so many advantages. You will get to know. So by next week, I will do the demonstration session, and the most of our live the Zoom these live classes also will be conducted through the platform. It is actually incorporated with Zoom, so you don't need to worry about the data. So the live classes will be through the Zoom, which is incorporated through the platform. So so what you can do, sometime maybe juniors, maybe students might not catch everything when I'm doing 4 hours class, when I'm telling a lot of stuff within a short period. You might feel some difficulty. So as we are going to give the restreaming, even I'm planning to give the live class recording also for all students. As it is having a lot of securities, you can't do anything. So you can recall it, you can rewatch it again and again. So I hope my target is to increase the Obgyn-Gynae pass rate to 100%. Right? So nothing I'm going to achieve by that. Only thing, everybody, all the future doctors will be a good person to this country. That is the only thing I want. Okay, great. So now you might have some idea what is PCOS and what you should know, right? So the PCOS is a complex metabolic syndrome, which is involving with your reproductive life as well as your general metabolic complications, right? So before we discuss about the risk factors and diagnostic criteria and all, I'm going to explain you what is the pathophysiology of the PCOS, why it is occur, right? So basically, the PCOS pathophysiology can be two types, right? There are two types. One, when you see the PCOS patients, okay, just shall we have some discussion? Okay, just tell me, right? Yeah, Kavita. So, can you identify a PCOS woman? Just having a look, can you identify? What do you think? By the appearance? What do you think? Is it possible? Yeah, of course, it is possible, right? So most of the time, we can identify the PCOS woman by the appearance, right? Okay, what is the commonest appearance in the PCOS woman? The commonest appearance, very good, obesity. They are just obese or maybe overweight. So basically, around 70% of women, 70% of women are obese, right? And of course, 30% of PCOS. So when somebody is very slim, you can't say, no, I don't have PCOS. Still, you can have PCOS. Roughly 20 to 30% of women, even though they are still lean body, they might have polycystic ovarian syndrome, right? They might have polycystic ovarian syndrome. So now you have an idea, these PCOS patients could be obese, could be an obese or lean body, right? Obese and lean body. So when you see the pathophysiology of the PCOS for this obese as well as the lean body, bit different, right? Bit different. So actually what is happening? Basically, when a woman becoming obese, right, what will happen? They will develop insulin resistance. They will develop insulin resistance. When they develop insulin resistance, can you identify whether this woman developing insulin resistance? Is there any way to identify the insulin resistance other than the investigations? Any clinical? Yeah, of course. You can identify the insulin resistance by identifying. So you can see the acanthosis and aggregates. What is acanthosis and aggregates? When you see the back of the neck, there might be a black color, velvety appearance. You can see some women, especially the obese women, might have black colors. Of course, my entire body is like a acanthosis, but when you see fair girls, of course, you can see like black color, velvety appearance in the back of the neck. That is called acanthosis nigricans, right? That is called acanthosis nigricans. Thank you, Janet. Right? That is called acanthosis nigricans. So when a woman developing insulin resistant, they will develop acanthosis nigricans. So when they develop insulin resistant, there are so many changes will occur in their metabolic conditions, metabolic status, endocrine function. So what are the changes? When somebody develop insulin resistant, what will happen to the secretion of insulin? What will happen to the secretion of insulin? When somebody develop resistant, to overcome the resistance, what will happen? More and more insulin will secrete. So basal insulin concentration will increase. Insulin is increasing. When the insulin increase, even though the insulin increase, the insulin resistant level is high. So when they have insulin resistant, what will happen? The glucose tolerance will impair. When the glucose tolerance impair, what will happen? They will develop Diabetes. When the insulin concentration increase, what will happen? The insulin is an anabolic hormone. So lipogenesis will increase. When lipogenesis increase, what will happen? A lot of fat will produce. Central obesity. Right? Central obesity. When the triacylglycerol and fat increase, what will happen? The cholesterol will increase. It will lead to hypertension. It will lead to dyslipidemia. It will lead to cardiovascular disease. Now you all can simply understand what is happening. So now you all can say what are the consequences of PCOS, because basically the PCOS also start with the insulin resistance. Now you all can understand why this menstrual irregularity is interconnected with the metabolic disorders. Basically this menstrual irregularity is interconnected because of the insulin resistance. Insulin resistant. Do you understand? So insulin resistant leading to the metabolic disorder. Same time, this insulin resistant will reduce the secretion of androgen binding protein or sex hormone binding globulin. What is this? What is this sex hormone binding globulin? So if you see the sex hormone, what is the sex hormone? Androgen is testosterone, right? So even though there is, right? Give me 1 minute. Right. So what is this sex hormone binding globulin or androgen binding protein? If you see this testosterone, so what is this testosterone? This testosterone is a derivative of cholesterol. Basically, testosterone is produced from the cholesterol. So cholesterol is a lipid, isn't it? Cholesterol is lipid. But the blood is water. Can lipid and water mix up? Can lipid and water mix up? No. So this lipid hormone, if this lipid hormone want to transfer through this water, because this lipid hormone is a hydrophobic, water resistant. So they can't go because it's not diffusing into the water. So they need some transport protein. They need transport protein. Right? So we need a transport protein. So this androgen binding globulin is a transport protein. So when you see the androgen, around 98% of the androgen are bind to the protein. Only 2% are present as a free form in the blood. So what is the significance of that? The significance is this free androgen has biological activity. Even though you are having 98% of androgen that is bind to the protein, it's not a biologically active one. It is a reservoir. Only this 2%, free 2% has biological activity. Do you understand? That 2% has biological activity. Now, because of the insulin resistance, your liver is not producing androgen binding globulin. So when you have reduction in androgen binding globulin, When you have reduction in androgen binding globulin, what will happen to the free form? What will happen to the free form? Free form will increase. When there is a elevated free androgen level, what will happen? That has biological activity. So what will happen? Increased level of androgenic activity. So this woman will have increased level of androgenic activity. So what are the effect of androgen? What are the effect of androgen? Acne, right? The pimples over the face. And hair distribution, increase hair growth. Hair might be, you might have hair or like a men. You are having a hair in the center part of the body, mainly center part of the body, facial hair, right? So increase hair development, hair follicles. So hirsutism, acne. When there is a very high level of androgen, of course, they might have voice change as well. Yeah, of course, androgenic alopecia. So when you see a male and female, usually the male will have some alopecia. This is called androgenic alopecia because we have testosterone. When the girl has elevated level of testosterone, they will have androgenic alopecia. So now you will understand what is happening. So basically, the insulin resistance leads to metabolic disorder. Insulin resistance lead to reduction in androgen production, which lead to free androgen fraction high. That free androgen will increase the androgenic activity. Do you understand? Right. So what is happening in the ovary? Now we have seen what is happening in the metabolic part, what is happening in the liver, and what is happening in the hypothalamo-pituitary ovarian axis. Hypothalamo-pituitary ovarian axis. So the insulin resistant, because of the insulin resistant, insulin-like growth factor, which is important for the follicular development, right? Insulin-like growth factor, which is important for the follicular development. So because of the insulin resistance, this increased activity, insulin-like growth factor will increase in the ovary. Okay, will increase in the ovary. When there is increased insulin-like growth factor, what will happen? Inside the ovary, as you study, just recall physiology which you have studied in your second year, we have two types of cells. One is granulosa cell and second one is theca cell. What is the function of granulosa cell? Granulosa cell will produce the estrogen inhibin. Theca cell will produce the androgen, isn't it? So the theca cell will produce the androgen, then androgen will transfer to the granulosa cell, then granulosa cell will produce the estrogen from the androgen by the enzyme called aromatase. So estrogen production will occur inside the ovary by theca cell and the granulosa cell. At the same time, estrogen can produce outside the ovary as well. How? This androgen, which is present in the blood, which is secreted from the ovary as well as adrenal gland, will convert to estrogen by the peripheral fatty tissue. There are two ways we can have estrogen production in a female body. One is inside the ovary by theca cell and granulosa cell. Second one is by the conversion of androgen to estrogen in the peripheral fatty tissue by enzyme called aromatase. Yes, very good. Fat aromatization. Right? Okay. We will come to that conversion as well. Now, because of the elevated insulin-like growth factor, basically due to insulin resistance. Now, insulin resistant, to overcome that, insulin-like growth factor is increasing. This insulin-like growth factor will stimulate the theca cell. So, when the theca cell stimulate, what will happen? Theca cell will produce more and more androgen. more and more androgen. Now, inside the ovary is now androgenic. The concentration of androgen production has increased. So because of the increased production of androgen, now the ovary is having a lot of androgen. What do you think? This androgen, is it a female hormone or male hormone? It's a male hormone. That androgenic environment inside the ovary will inhibit the follicular development. Follicles are developing from primordial follicle, primary follicle, secondary follicle, Graafian follicle, and finally follicle will rupture and ovum will release. This is your normal menstrual cycle. Primordial follicle will develop into primary follicle will develop into secondary follicle will develop into Graafian follicle, and Graafian follicle will rupture and ovum will release. For this development, actually you need estrogen. You need estrogenic environment, but because of the insulin-like growth factor, androgen secretion has increased. So now ovary is androgenic. Ovary is androgenic. So why this ovary is androgenic? Because Theca cells are producing more and more androgen. Theca cells are producing more and more androgen. So that's why you have a lot of androgen inside the ovary. Because of this androgenic environment, this follicular development will get harassed in halfway. So it got harassed in secondary follicle. It's not developing into Graafian follicle. So if it is not developing into Graafian follicle, what will happen? This ovum can't release. So ultimately, these follicles are developing, of course, but it got harassed in halfway. Multiple follicles are developing, and everything is getting harassed in halfway. That's why we are getting multiple follicles. And as you have this follicular development, as you have more androgen production, those androgen will convert to estrogen. So what will happen? The amount of estrogen also will be high. So now you can see in this woman, right, in her blood, sex hormone binding globulin reduce. Insulin-like growth factor increase. Free androgen increase. And what has happened to the production of androgen? That increase. So what will happen to the total androgen? Free as well as bind. What will happen to the total androgen? That is also increased. These are the MCQs. What will happen to the total androgen? What will happen to the free androgen? What will happen to the bind androgen? What will happen to the bind androgen? What will happen to the bind androgen? Reduce. Very good. Why it is reduced? Because the protein has reduced. Now you will, very good, you will understand now, right? So total androgen also increased because of the production, increased production, and the free androgen increased because two reasons: one, production increase; second one, binding protein reduce, right? So because of the free androgen, the peripheral tissue will convert androgen to estrogen. So what will happen to the estrogen concentration? Will goes up. And also the granulosa cell also will produce more and more estrogen. Why? Because Theca cell provide a lot of materials. So what will happen to the estrogen level? Will increase. So this increase estrogen, increase inhibin, what will happen? It will go to the pituitary in a negative feedback manner. It will go to the pituitary. This will inhibit the FSH secretion. Why? As we know, when the follicles are developing, estrogen and inhibin will release from the ovary. That will inhibit the FSH secretion, follicular development. Because the ovary is having a lot of developing follicle. They are a problem, but follicles are developing. No need of additional FSH for the further development. So what will happen? The feedback inhibition will inhibit the FSH secretion. So when the FSH secretion inhibit, what will happen to the FSH concentration in the blood? When the FSH pituitary is inhibited by the estrogen and inhibin, what will happen to the FSH secretion from the pituitary? Decrease. So the FSH concentration in the blood will come down. So then what will happen to the LH concentration? Will be higher than the FSH. So usually when you see the follicular phase, FSH will be higher than LH. But in PCOS, it will convert to other way around. LH will be higher than FSH. But still, LH concentration will be usually within the normal range because LH secretion is not increasing. Do you understand? LH secretion is not increasing much. The problem is FSH secretion come down. That's why the proportion has increased. Do you all understand? Are you all following me? So, because there are MCQs. In PCOS, LH secretion will increase. LH concentration will be higher than the normal value. True or false? False. It's in the normal value, but the person FSH LH ratio will change. LH ratio will be higher than the FSH. Do you all understand? Right? Now you all know what is happening in your reproductive life. Right? So actually the follicle got arrested. There is no ovulation. There is the estrogen concentration going up. Right? Estrogen concentration is going up, and inhibin concentration is going up. So okay, there is a question, sir. Estrogen inhibit pituitary, then both FSH and LH reduce. Why only FSH? The reason is when the follicles are developing, this developing follicle next they need the LH surge. When the follicles developing, actually the later part mid-cycle, what will happen? Suddenly the LH surge will occur. So normally the inhibition of this inhibition of the estrogen and inhibin level will be higher towards the FSH than the LH. Do you understand? Right? Okay. Now, what will happen when these changes occur? When the follicle got arrested, there is no Graafian follicle. Without Graafian follicle, can you have ovulation? No. So without Graafian follicle, can you have LH surge? Of course, no. So suboptimal LH surge will occur. Actually, you need a LH surge. Here, this LH surge will be suboptimal. That is also one of the reasons for the elevated LH level, the ratio. Suboptimal LH surge. So, the ovarian development got arrested, no Graafian follicles, or delayed follicular development. So, the ovum release will be delayed or ovum release will be stopped. So, there is no ovulation. Without ovulation, can you have progesterone? Can you have progesterone? If the follicle rupture only, you will have corpus luteum. Then only you will have progesterone. So without progesterone, can you have secretory phase of endometrium? No. Your endometrium is going to be exposed to estrogen continuously. Your endometrium is not exposed to progesterone. Your endometrium will not shed off. So you will not have menstrual bleeding. You will not have menstrual bleeding. So you might get menstrual bleeding maybe once in a month, or once in 2 months, once in 3 months, once in 4 months, once in 5 months. Why? Because your endometrium is not exposing to progesterone. Your endometrium is not exposing to cyclical hormonal change. No ovulation, no menstruation. Without ovulation, can you have baby? No, you can't produce the baby. Do you all understand? You can't produce the baby. The meantime, without progesterone, your endometrium is continuously exposed to what? What hormone? What is the hormone produced by the ovary right now? Estrogen. So the endometrium is continuously exposed to estrogen. What is the function of estrogen in endometrium? What is the function?
Proliferation of the endometrium.
Very good. Proliferation of endometrium. So the endometrium is continuously proliferate for 3 months, 4 months, 5 months, 6 months. When there is an excessive proliferation, when the cells are dividing more and more, what is the risk? Hyperplasia.
Endometrial cancer.
Very good. Hyperplasia and endometrial malignancy. So basically, this PCOS is a risk factor for endometrial CA. When somebody not exposed to progesterone, when somebody continuously exposed to estrogen, what will happen? They are having high risk to develop endometrial CA. Now you all can simply think and answer. PCOS is a risk factor for endometrial CA. True or false? True. We know because the endometrium is exposed to estrogen for a long time. Do you understand? Right? Okay. So this endometrium is exposed to estrogen for 3 months. So then what will happen to the endometrial thickness? What will happen to the endometrial thickness? Increase. Thickness is increased because continuously it's proliferating. So endometrial thickness is increasing. So after 3 months, somehow she ovulates and she's having a menstrual bleeding. When she is having menstrual bleeding, what will happen? When there is a thickened endometrium. So the thickness of the endometrium is high. So then the shed off will be more. So when there is more tissue shed off, what will happen? Bleeding will be high. So bleeding will be high. Right? And of course, I have taught you during the menstrual cycle, physiology of the menstrual cycle, when somebody has menstrual bleeding, how that menstrual bleeding getting arrested. There are mechanisms for the arrest of menstrual bleeding. One is uterine contraction. Second one is your coagulation method. Third one is regeneration of the endometrium. Why they are having menstrual bleeding? Because endometrium has damage and shed off. So there is a lesion. That's why through the lesion, there are bleeding. So when the damaged area is healing, bleeding will arrest. So regeneration of the endometrium after shed off. For the endometrial regeneration, what is the hormone you need? What is the hormone you need? For the endometrial regeneration, reproliferation, estrogen. So how the estrogen produced? Actually by the follicular development. So when there is a PCOS lady, a girl, when the endometrium shed off, she needs estrogen for the regeneration. What do you think about the speed of follicular development for a normal girl and PCOS girl? Obviously, PCOS girl will take more days for the development. Their follicular development will be slower. So, estrogen production also will get some delay. So, when you get delay in production of estrogen, what will happen? Regeneration also will get delay. So, for a normal woman, the regeneration might occur within 2 to 3 days. So what will happen? Their menstrual bleeding will arrest within 2 to 3 days. That's why for a normal woman, we are having menstrual bleeding for 3 to 5 days. Maximum 5 days, then bleeding will arrest. But for a PCOS woman, you need more days, more time for the regeneration. So then what will happen to the duration of the menstrual cycle? Will it prolong? Do you all understand? So amount of blood will be high, duration of the menstrual cycle will be more, and the frequency of the cycle will be less. Actually, they will have one cycle, maybe 2-3 months, once in 3 months. Do you all understand? Do you all understand? So if it is a PCOS woman, they might have menstrual irregularity like this. Their cycle are very infrequent. They might get cycle maybe once in 2 months, once in 3 months. How do you call that? Less frequent cycle. How do you call that?
Irregular menstrual cycle?
No. There is a name. Oligomenorrhea. Getting menstrual cycle in infrequent way. Once in 2 months, once in 3 months, once in 4 months. That is called oligomenorrhea. So one of the menstrual irregularity in the PCOS woman is oligomenorrhea. Once they get the period, it will be heavy. How do you call heavy menstrual bleeding? That is called menorrhagia. Right? So they are having infrequent cycle, but those cycles are heavy and prolonged. Now you all understand what is happening, why it is. Do you understand what is happening and why it is? So these are the menstrual irregularity in that woman due to this PCOS. Right? Okay. What do you think about the ovarian malignancy risk in PCOS?
It does not affect?
Low. Actually, not, you can't say not affect. It is less. Because why the ovarian malignancy risk is high means when the follicle develop and release, this ovarian epithelium will damage and follicle will come out, egg will come out. Then that damaged tissue will proliferate and heal. Then release, damage. So every month your epithelium is damaging and regenerating, damaging and regenerating, damaging and regenerating. So the cell proliferation will be high when you have more damage. So when a woman has regular menstrual cycle every month, their damage is more and risk of malignancy is high. What is happening in PCOS? Are they having regular damage, monthly damage, or less frequent damage?
Less frequent damage?
So when they have less frequent damage, what will happen to the risk of ovarian CA? It is less. Do you all understand? So please don't memorize anything. So now you all can understand what is happening, why it is. Now you all can understand why it is causing diabetes, why it is causing hypertension, why it is causing dyslipidemia, why it is causing central obesity, all these metabolic syndrome, why it is causing hyperandrogenic features. You all know why it is causing menstrual irregularity, why it is causing subfertility. So basically 70% of PCOS women have this pathology. It's due to this. Do you all understand? Great. So then what will happen to the rest of the 30%? Lean body one. For the lean body one, basically, their pathophysiology is quite different. So what is happening? Actually, they are having a hyper LH secretion. In that 20 to 30% of women, they are having excessive LH secretion. So what is the function of LH in the ovary? Actually, this LH will increase the TCA cell activity. So they are basically very lean. They don't have much insulin resistance. They don't have much this metabolic disorders, but still they are having hyperandrogenic condition because of the LH secretion. So when they have hyperandrogenic secretion, what will happen? Their androgenic free androgen level will increase because of the excessive androgen production. then they might have the androgenic effect. And this hyperandrogenic condition in the ovary will inhibit the follicular development and got arrest, and they are having polycystic. So these are the two pathophysiology in PCOS. Now you all can simply understand what is the pathophysiology. What are the complications? I don't want to teach. Do I want to teach the complications separately? What are the complications of PCOS? No need, because you all know. Okay. PCOS can lead to gestational diabetes mellitus. True or false?
True. Insulin resistance?
Very good. True, because it is developing insulin resistance. Do you all understand? It's simple, right? You don't need to worry much. Right? Because this PCOS will cause all the metabolic disorders. Right. When a woman becoming obese, what will happen to their airway? When somebody become obese, what will happen to their airway? Airway
Obstructed.
very good. Airway obstruction, especially when they are sleeping. So when they are sleeping, the airway will get obstructed. How do you call that? So then they can't sleep, they can't breathe.
Sleep apnea.
Very good.
Sleep
Obstructive sleep apnea. So when you are obese, that's why the corona is risk for the obese woman. Because corona will affect the lungs and already they are having airway obstruction, so it will worsen the condition. Do you understand? So the PCOS can lead to obstructive sleep apnea, excessive weight. Right? So when there is an excessive weight, what will happen? Bones are getting eroded and they can easily develop osteoporosis, osteoarthritis. Do you understand? So now you can see, right? You have seen the metabolic disorders. You have seen the complication due to obesity. You have seen the complication in their menstrual cycle. You have seen the complication or impact on their reproduction. Okay? Even though they become pregnant, these PCOS, they have a lot of complication. PCOS itself is a risk factor for miscarriage. PCOS itself is a risk factor for miscarriage. If it is an obese becoming pregnant, what will happen? Their labor might get harassed. They are high risk to develop shoulder dystocia. They are high risk to develop postpartum hemorrhage. They are high risk to develop deep vein thrombosis. Obesity is a risk factor for deep vein thrombosis. Do you understand? And this woman, yeah, high level of estrogen can cause breast CA. Yeah, it has effect, right? And this woman, these girls, she's 22 years, 23 years with obese body. There are facial hair. She couldn't go outside. People are seeing and people are commenting about her, right? So no one is citing her, right? So what will happen? She feels depressed. Depression. It is affecting her quality of life. It is affecting her psychological part. So now you all understand this PCOS has impact in a woman every aspect. Their metabolic, menstrual, reproduction, their appearance, quality, and psychology. Everywhere it has impact. All kind of this complication is basically from a single reason. What is that? Everything is developed from a single reason. What is that? Obesity, insulin resistance. So if you want to correct all these problems, what you have to do? What is your ultimate target of the management?
Exercises, lifestyle modification.
Weight reduction. Very good. Exercise, lifestyle modification, maybe a medical treatment to reduce her weight. Do you understand? You don't need to do high-fi sophisticated management. Just simple management which we can do easily. That is your weight reduction. So simply what you have to do is you have to advise the patient to reduce the weight. That's it, nothing else. Once they reduce the weight, everything will settle down. Everything will settle down. For the lean body PCOS management, no worries. I will come to the management. Wait. Don't be hurried. Right. So basically what you want to do is you want to reduce the weight. That's all. In addition to that, because weight reduction, do you think it is an easy task to reduce the weight? It is an easy task? No, it's not an easy task. It takes time. So until you reach your target, this woman might have some other concern, like her appearance. She want to remove the hair. So then you can do some specific management for the particular things to reduce the hair, to reduce the acne, to make the period happen, to regularize the period, to become pregnant, to manage diabetes. Do you understand? To manage depression. So you may have to treat the symptoms and complication. In addition to that, you have to treat the core problem, that is the weight reduction. Without advising the patient to reduce the weight, treating with drugs, not going to work at all. Basically, you are going to manage her by weight reduction. In addition to that, to reduce problems in a quick manner and temporary manner, you are giving few treatment. We will discuss how you are going to manage the hirsutism, how you are going to manage the acne, how you are going to manage the fertility, how you are going to manage the menstrual irregularity. Those things we will discuss a bit later after the discussion of diagnosis. Do you all understand? Are you all following me? Great. So the management of lean body PCOS is a bit different. I will come to the management part a bit later. Okay. Now, how are you going to manage this PCOS? Sorry, diagnose this PCOS. How are you going to diagnose the PCOS? Yeah, how are you going to diagnose the PCOS? Very good. To diagnose the PCOS, we are using a criteria called Rotterdam criteria. Right. So I will teach you what is this Rotterdam criteria. Right. So this Rotterdam criteria has 3 components. Right. This Rotterdam criteria has 3 components. Out of these 3 components, if you have two out of these 3 components positive, you can diagnose polycystic ovarian syndrome. Right. So you need to know about this Rotterdam criteria. Second thing, you need to know what are the components in the Rotterdam criteria. And third one, you need to know how to diagnose from this Rotterdam criteria. So Rotterdam criteria has 3 components, and 3 out of 2, it's diagnosis. Okay, just tell me, what are those 3 components of
Hirsutism, acanthosis nigricans, and sexual binding protein is very high.
Right. Okay. So those three criteria are: 1, your menstrual problem; second one, your ultrasound criteria; third one, your clinical and biochemical criteria. So one is menstrual, second one is ultrasound, third one is clinical and biochemical. So menstrual irregularity, usually oligomenorrhea, right? Around 70-75% of women will have oligomenorrhea. 25% will have normal cycle, but still that is one criteria: oligomenorrhea, menstrual irregularity. If somebody has oligomenorrhea, they are fulfilling one criteria. Second criteria, ultrasound one. Ultrasound appearance of polycystic ovary. Ultrasound appearance polycystic ovary. How to diagnose the polycystic ovary? Appearance of 12 or more cyst in the ovary. More than 7 millimeter cyst. More than 12. 12 or more cyst in the ovary, you can say it's polycystic. Or if the ovarian volume more than 10 milliliter, there are two criteria to fulfill your ovary. One is 12 or more follicle. Second one is ovarian volume for that more than 10 milliliter. If it is fulfilling that ultrasound criteria, then second criteria. Third one, clinical or biochemical evidence of hyperandrogenism. Clinical or biochemical evidence of hyperandrogenism. What are the clinical evidence of hyperandrogenism? Acne, hirsutism, deepening of voice. Those are clinical evidence of alopecia. Clinical evidence of hyperandrogenism. Then, as Nimalshi said, biochemical evidence. Elevated androgen level. Or free androgen index. Actually, you don't need to know about the free androgen index. So free androgen index also will be high, more than 2.5. So free androgen index, it means the androgen free form is high. Free androgen index is high. Free androgen index or elevated androgen level. Actually, the amount of sex hormone binding globulin, it's not included into the criteria. Obesity is not included into the criteria. The obesity, decrease androgen level, sex hormone binding globulin, those are features, but those are not included into the criteria. You have to be very careful about this. When you come to the MCQ, these are the things they will assess you. So you should know what are the criteria. Criteria has only three components. One is menstrual regularity. Second one is polycystic appearance, which means more than 12 or more follicle, more than 7 millimeter, or ovarian volume more than 10 milliliter. And third one is clinical or biochemical evidence of hyperandrogenism. Those are the only thing included into the criteria. So if you have polycystic ovary and hyperandrogenism features, then you have two, then it's diagnosis. Or if you have polycystic ovary and menstrual irregularity, you have 2 out of 3, then it's diagnosed PCOS. So in these 3, if you have 2, you can diagnose. So can you have polycystic ovarian syndrome without having polycystic ovary? Can you have polycystic ovarian syndrome without having polycystic ovary? Yes or no? Yes. Because
other
out of these 3, you can have menstrual irregularity and androgenic features. So 2 are positive. Then you can have polycystic ovarian syndrome. That's why at the beginning I have told you, polycystic ovary and polycystic ovarian syndrome are different. Both are not same. Do you all understand right now? The polycystic ovary and polycystic ovarian syndrome are different, not same. Polycystic ovarian syndrome is a complex one. It is different. You can diagnose even without polycystic ovary. You can't say to diagnose polycystic ovarian syndrome, you need to have polycystic ovary. You don't need to have polycystic ovary. Can you have polycystic ovarian syndrome without menstrual cycle, with menstrual irregularity? Yeah. You can have other two. Menstrual irregularity might not be there, but still there, polycystic ovarian syndrome. Can you have PCOS without hyperandrogenic features?
Yes. Other two.
Other two. Now you all can understand what is PCOS. Now you all can answer whatever the question comes. Now, of course, we are going to discuss few questions. Then you will understand how much you understood this subject. Those of your past paper question, I just put it because to make you to understand what is the correct way of study. Right? So when you do the question, we will realize how we studied today. Right? Are you all clear up to now? We have discussed about what is polycystic ovarian syndrome, what is the pathophysiology of polycystic ovarian syndrome, what are the complications of polycystic ovarian syndrome, and how to diagnose. So when you study the theory, actually you need to understand what is it. So tomorrow, a lot of students already joined. So the students who didn't join, you can join tomorrow. I'm starting the theory again. So you can join. Even the already joined student also can join and watch the classes because you are getting free access now for that classes. So you can join. Right. Okay. What is ovarian volume? The volume is what is volume? Right. So what is the volume of ovary? That is ovarian volume. Okay. How are we going to manage? So management, I will show you a few pictures of management. Give me 1 minute. I will share the presentation. Right. Okay, great. So, of course, this is the typical appearance of polycystic ovary, right? You can see here, there are so many follicles in their surface. There are so many follicles. This is the laparoscopic appearance of the ovary, right? Now, this is the pathophysiology already we have discussed, right? And of course, the clinical features, oligomenorrhea or maybe amenorrhea, hirsutism, acne, acanthosis, obesity, infertility, right? Virilization, right? So you can see. So the acne, right? So mainly the facial hair, yeah. And you can see this mainly the center part of the body, central hair distribution, usually the chest hairs and the center part of the tummy, you might have hair, right? And of course, we have discussed about the Rotterdam criteria, and the differential diagnosis could be hypothyroidism or hyperprolactinemia, which can cause oligomenorrhea or amenorrhea, and congenital adrenal hyperplasia, which can cause elevated androgen, and ovarian or androgen tumor, which also can produce more androgen, and it might mimic the PCOS and Cushing syndrome, same pathology, and some drugs which has androgenic activity. So basically, if you understand the pathophysiology, so everything is interconnected with the androgen, congenital adrenal hyperplasia, ovarian or adrenal tumor, Cushing syndrome, androgen drugs. So all are interconnected with hyperandrogenism. Right. So investigation, of course, we have discussed ultrasound scan, free androgen index, right? And FSH LH ratio. The LH will be higher than the FSH. And this is the appearance, ultrasonic appearance. You can see right around the ovary. You can see one follicle here, another follicle, another follicle, another follicle, another follicle, another follicle, another follicle, another follicle. So when you see, there is the rounded multiple follicles. It is look like how it is look like.
Ground glass?
No, not the ground glass. This is called pearl ring appearance. Right. So this is called your polycystic ovary. Right. How are we going to manage? So as I told you, so basically we are managing with the weight reduction for obese. First, we will discuss about the obese PCOS management. Then we will discuss about the lean body PCOS. So if it is a obese one, so weight reduction, lifestyle modification and weight reduction. So maybe exercise, dieting, so everything, stress management, so lifestyle modification. Then of course, depend on the symptoms, we may have to treat. So every symptom we will discuss, hirsutism, how we are going to manage. Ultimately, you can manage everything with the weight reduction. In addition to that, of course, we are managing each and every symptoms. If it is a hirsutism, you can treat them locally or systemically. So local therapy, like temporary, like a plucking, waxing, saving, you can shaving, right? So those are symptomatic temporary measures. Or maybe permanent, you can do the laser ablation of the hair follicles, electrolysis, right? Or you can treat them systemically. How can you treat systemically? Basically, what you have to do, you have to reduce the action of androgen. You have to reduce the action of androgen. So the medication which you are giving to that particular woman should have anti-androgenic property. Basically, you are giving the medication which should have anti-androgenic property. So you can give simple OCP which will reduce the hirsutism. How? Because when you give the OCP, this OCP will inhibit the pituitary. So what will happen? When the pituitary gets infected, of the LH secretion will reduce. When the LH secretion reduce, what will happen? That will reduce the stimulation of the TK cell. So androgen secretion will reduce. That is one. Second, this COCP will stimulate the liver to produce sex hormone binding globulin. So when you stimulate the sex hormone binding globulin, what will happen to the free androgen level? What will happen to the free androgen level? Reduce. So their androgenic effect will reduce. So you can give simply COCP for maybe 3 months or 6 months. Actually, for the hirsutism treatment, giving for 1 month or 2 months is not enough. You need to give them for minimum of 3 months up to 6 months. The reason is, once the hair follicle formed, it's already formed. When you give the COCP or maybe anti-androgen drug, it won't kill the pre-existing hair follicle. What will happen? It will reduce the new hair follicle production. So that existing hair follicle should fall down naturally. When there is no new hair follicular development, already previously formed one is falling down. So with the time, it will disappear. So you need to wait minimum 3 to 6 months. By taking anti-androgen drug or OCP for 1 month, you can't see the effect. So if you have a wedding in month time, you can't change your appearance by reducing the weight within month. You can't change your appearance by taking this medication within month. So then what you have to do? You have to go for a temporary method. Maybe shave, maybe plucking, maybe laser ablation. You have to go to the temporary measures. But if you have time, right, you are not going to marry right now, you don't need to be hurry. You can take your time and reduce your androgen level. Then you do weight reduction. If you want to get married, maybe 3 to 4 months, 3 months, 4 months, 5 months. So then weight reduction itself, it's not going to work immediately. Then you can use this OCP, systemic. So you have to think rationally. Now I have taught you the basic pathophysiology, and I have taught you the options are available. So there is no fixed management for the hirsutism. Fixed management and best management is weight reduction. There is no question. But depend on the condition, you have to think rationally and you have to answer. So the patient is worrying about her appearance and she's having severe hirsutism and she's having marriage in a month's time, and she came to you. What is the best management for her? Laser treatment, COCP, weight reduction. Which one is best? Which
Laser.
one is best? Laser.
Yes.
Laser. Because as even though we know we have to reduce the weight, there is no question, but within a month you can't achieve because she's worrying about her appearance for the marriage. So then you need to think about that. Rational thinking. Do you understand? Right, great. So infertility in PCOS. So they might have infertility. So what you can do, you can just ask them to reduce the weight. And of course, their follicle got harassed. You need to stimulate this follicle to develop. How to stimulate? You can induce the ovulation. How to do the ovulation induction? You can give some medication. There are medication to induce the ovulation. You can give FSH, you can give clomiphene, you can give letrozole. There are different hormones or drugs which we can use for the ovulation induction. Or sometimes we are doing ovarian drilling. What is the mechanism of ovarian drilling? What is ovarian drilling? We are putting the laparoscope and we are burning the peripheral ovarian tissue by putting a hole with the electricity. With the electricity, we are burning the peripheral tissue of this ovary. That is called ovarian drilling. Usually we put 4 holes. Why we are burning the peripheral tissue of the ovary? Because as we discussed a bit earlier, the reason why this ovary is not developing the egg is the ovary is hyperandrogenic stage. The TK cell is producing more and more androgen. So by burning the ovarian peripheral tissue, what you are doing is you are burning the TK cell. When you burn the TK cell, what will happen? Androgen production will reduce. When the androgen production reduce, what will happen to the ovum development? Will increase. That is the mechanism of ovarian drilling. Do you all understand? So of course you need to do the weight reduction. At the same time you can do ovarian drilling. And basically we know why this PCOS developed because of the insulin resistance. Can you reduce the insulin resistance? Is there any way to reduce the insulin resistance?
Metformin, like drugs?
Yes, you can give insulin sensitizing agent. The commonest insulin sensitizing agent which we are using is metformin. So giving metformin for a PCOS woman is to increase the insulin sensitivity, not to reduce the weight. Do you all understand? Because most of the women are thinking metformin will reduce the weight. Is it reducing the weight? No. The purpose of giving metformin in PCOS is not to reduce the weight, is to increase the insulin sensitivity. Do you understand? So we are giving insulin to increase the insulin sensitivity. Metformin will increase the insulin sensitivity. How can you reduce the weight? Exercise. Diet. If it is not reducing or if it is obese, then you can use few medication. What is the medication? Have you heard about Orlistat? Have you heard about the drug called Orlistat? Yes. What is this Orlistat? Orlistat is lipase inhibitor. So when you give the lipase inhibitor, what will happen? Lipase inhibitor will inhibit the lipase. So lipid digestion will not occur. When there is no lipid digestion, what will happen? This lipid material which is present in the food will coat the carbohydrate as well. So the carbohydrate digestion by the enzymes will be inhibited because of the lipid coat. So what will happen? Carbohydrate will not taken in. Right? will not take it in. So then it will come out. Yeah, give me 1 minute. My on-call SHO is calling. Right? So we can give the ovulation induction. We can give for the infertility, we can do the weight reduction. So how we are going to do the weight reduction? Lifestyle modification, exercise, food, and Olistat. Yeah, of course, Olistat is recommended in Sri Lanka. It is available in Sri Lanka. And if it is morbid obese, it's not responding anything, then you can go for a surgical method. Have you heard about bariatric surgery? Have you heard about bariatric surgeries? Right, partial amputation or partial, so bisect the stomach, or maybe you can put the band. So we can do the bariatric surgeries. Okay, there was a question from the students. When you do the ovarian drilling, won't it affect the primary follicle? What do you think? Will it damage the primary follicle? Of course. If Tika cell is damaging, means the follicles are damaging. Of course, it's damaging. But we don't have the other option. That's why we limit the hole only 4, not more than that. Because when you do more hole, more follicle will get damaged. Okay, great. So menstrual disturbance, how we are going to manage? Of course, we need to ask them to do the weight reduction. But our worry is when the endometrium exposed to estrogen for a long time, as we discussed, it is high risk for the ovarian cancer. So you need to break through this endometrium. So when somebody has amenorrhea for more than 3 months due to PCOS, it has high risk to develop endometrial hyperplasia and CA. So first thing what you have to do, you have to shed off the endometrium. How can you shed off the endometrium? You can give progesterone for 5 days. Give progesterone for 5 days. Maybe nodisterone, Primalute, whatever. Oral progesterone for 5 days. When you give 5 days progesterone and stop it, because of the withdrawal of progesterone, endometrium will shed off. So withdrawal bleeding by progesterone when somebody have amenorrhea for more than 3 months. If it is less than 3 months, you can wait. But more than 3 months has high risk for the hyperplasia and malignancy. You need to give the treatment for endometrial shed off. Okay. And of course, you can regularize the period by giving drugs like OCP. When you give the OCP, it will regularize the cycle. So you can do the weight reduction, give OCP, and withdrawal bleeding for a prolonged amenorrhea. But if the patient is subfertile, of course, you can't give OCP because that will worsen the subfertile part. So then what you can do, you can withdraw the bleeding and give the ovulation induction. When the ovum is induced and ovum is released, then automatically she will have bleeding. So for the subfertility, we are not giving the OCP, we are giving ovulation induction. Okay, right, perfect. So, of course, we have discussed about the long-term consequences. And so regarding the hirsutism management, of course, what you have to do is you have to give some medication as a systemic management. Have you heard about kryptonate acetate? That is a progestin which have anti-androgen activity. So OCP, the oral contraceptive pills, is combined with the estrogen and kryptonate acetate. What is the name of the drug? It's a famous drug, is DIAN-35. That is the drug we are giving for the woman. This DIAN-35 will have progestin and estrogen. That progestin is third generation progestin, that is cyproterone acetate, that has anti-androgenic activity. So estrogen will increase the sex hormone binding globulin, and cyproterone acetate will reduce the androgenic activity. Ultimately, their androgenic side effect will improve. Okay, and of course, as we know, this PCOS has some risk for the diabetes. You have to exclude the diabetes. For that, you need to do the oral glucose tolerance test. And to exclude the dyslipidemia, of course, you need to do the lipid profile, and you have to check the blood pressure, because you need to find out all kind of complications which can occur due to PCOS. Any question? Shall we move to MCQs and SBA? Do you all have any questions? Yeah, any questions? No. Right. Okay, I'm going to read this question. You all, I'm expecting you to answer, right? A 24-year-old, sir, will you post this presentation in this group? This presentation will be available in my platform. You can download it. Yeah. A 24-year-old obese, unmarried lady presented to the gynecology clinic with irregular menstrual bleeding and hirsutism. Her BMI is 30. She is expecting to marry within next 3 months period and worries about her appearance. What is the most appropriate management? Yeah, answer please.
Start cyproterone acetate, because it's 3 months. It's like we want short period option. It's not weight reduction option.
Yeah. Okay. First of all, when you read this question, you need to understand the question first. 24 years, unmarried. That is the most important part. And obese. Unmarried obese. She came with irregular menstrual cycle and hirsutism. So what is the diagnosis? Irregular menstrual cycle and hirsutism. What is your diagnosis?
Polycystic ovarian syndrome.
Because it has two criteria: menstrual regularity and hyperandrogenism. So we know this is a PCOS according to the Rotterdam criteria. The BMI is 30. So there is no question she has to reduce her weight. There is no question on that. Okay, she has to reduce her weight. That is the most important step. But she's expecting to marry within 3 months of period. So weight reduction, which lead to hirsutism reduction, it's a long process. It takes time, but she needs the outcome within 3 months. And she's worried about her appearance. So she wanted to change her appearance within 3 months of time. So what would be the best option is, you have to give systemic anti-androgen treatment. Right? So this is what we say is a single best. Because if it is an MCQ, you can say true for the cyproterone acetate as well as weight reduction, COCP. All are true. But among the correct answers, you have to select the best answer. Most of the answers are correct. But among the correct answer, you need to select the best answer. What is the best answer for this question? So you can't, now you don't, please don't think, sir, at all, if it is a hirsutism, we need to give cyproterone acetate. For this question, for her need, the cyproterone acetate is best one. Right? So if it is a 19-year-old lady, she did the A-level and she's waiting for the university and she's having hirsutism, what is the best management for her? What is the best management?
COCP?
No weight reduction. She's an obese, 19 years. She does not have any urge oh, very hurry to do this appearance change. So she can do the best one is weight reduction, exercise. Do you understand? So depend on the question, your answer might vary. So always you have to think about that. Right? Okay, perfect. So the answer for first question is A. Second one. A 30-year-old lady came with history of infertility for 1 year. 30-year-old lady, she's having infertility for 1 year. On examination, her BMI is more than 35. She was diagnosed with PCOS. What is the best management option?
Weight reduction. That much obvious. We have to do weight reduction plus lifestyle modification.
Very good. That is how you need to think. She's 30, right? She's 30 and she's obese, more than 35. So for this condition, you have to think about the weight reduction. Along with the weight reduction, we are doing other things as well. What? We are starting the metformin for increased insulin sensitivity. We can give the ovulation induction. So all are correct. But the best one for this patient is weight reduction. Because that is the one you have to do must. Along with, you can do rest of the things as well. Good. Question number 3. A 25-year-old unmarried woman presented to the gynecology clinic with amenorrhea for 6 months. 25 years, unmarried woman presented to the clinic with a history of amenorrhea for 6 months. Ultrasound showing polycystic morphology. The investigations and hormonal assay are normal. What is the most rational management? What is the most rational management?
Induce without bleeding with progesterone like, because it's 6 month amenorrhea, like have to be endometrial hyperplasia. We have
very good. Very good, right? Okay. Here, just go through the question again. A 25-year-old unmarried. She came with amenorrhea for 6 months and ultrasound scan shows polycystic morphology. So what is the diagnosis?
Polycystic ovarian syndrome.
So PCOS woman with amenorrhea for 6 months. What is your worry?
Oligomenorrhea.
PCOS woman with 6 months of amenorrhea. What is your worry? As you said, this is a high risk condition for hyperplasia. Right? This is the high risk condition for hyperplasia and malignancy. So what you have to do, you have to, first of all, I told you, if it is more than 3 months, amenorrhea for more than 3 months is an indication for the withdrawal bleeding. That is the most rational management for her now. You can do the weight reduction, you can do rest of the things later. But first of all, you need to reduce the risk of malignancy. That is the most important part. I will agree with that. Now you will understand how we are selecting the answer, how the answer is changing. So without knowing the basic fundamental knowledge, you can't select the answer in this way. So the most suitable answer is reduce or induce withdrawal bleeding with progesterone or something. B. Okay. True or false? Regarding the polycystic ovarian syndrome. Regarding the polycystic ovarian syndrome, it leads to ovarian cancer. False, right? I told you. When there is, yeah, it's reduced. When there is less number of ovulation, ovarian cancer risk is less. False. It results in irreversible hirsutism.
Not irreversible, it's reversible, can reverse.
Yeah, because of the androgen hyperandrogenism, she developed hirsutism. Once the androgen level come down, the hirsutism will improve. Once she reduces the weight, her hirsutism will improve. This is not irreversible hirsutism. It is reversible hirsutism. Very good. Obesity is a diagnostic criteria.
No, it's false. Not Rotterdam criteria is not diagnostic.
Yeah, the obesity is not included into the Rotterdam criteria. Right? obesity, it's not included into the Rotterdam criteria. So this is not the diagnostic criteria. So it's false. Peripheral insulin resistant is a feature.
Yes, true, because like acanthosis nigrans, acne.
Yeah. So peripheral insulin feature resistance is a feature. That's true. Increase in FSH is required in diagnosis.
Fall is LH and FS ratio should be not only for FSH.
Very good. FSH, LH to FSH ratio will vary, but FSH level won't increase. It will reduce actually. So answer is false, 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 true, false. See how you are answering the question. Because now you all know the basic pathophysiology. Do you understand once what is the importance of knowing the basic pathophysiology? So the shallow studies are not going to work. That is the reason previously you had only 30% pass rate. This is the reason now you have 90% pass rate. Great. Features of PCOS include acanthosis nigricans.
True.
True. Hirsutism.
True.
True. Central obesity.
True.
Endometrial hyperplasia.
It's not a feature, it's a clinical diagnosis. Like it's not the main feature.
Not a feature. Very good. Endometrial hyperplasia, it's not a feature, it is a complication. When there is a excessive estrogen production and prolonged amenorrhea, it can cause hyperplasia. It is not a feature. So it's false. Underdevelopment of the breast.
It's also not feature, can be lead like complicated, like estrogen much increase lead to and breast CA.
Yeah, it can lead to breast CA, but it won't cause underdevelopment of breast. So it is not the underdevelopment of breast, because when you have estrogen, actually it won't cause underdevelopment. Actually, the breast development will be all right. So it's false. So features of PCOS include acanthosis, true, 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 false, false. Right. The next question. In polycystic ovarian syndrome, testosterone level increase.
True.
True. Very good. It's true. Low basal insulin level.
Not low. It's insulin resistance, so it should be low. True.
No, think about that. If it is an insulin resistant, what will happen to the concentration of insulin? I told you.
Decrease.
To overcome the resistance, the amount of insulin will
reduce high.
High. Yeah, because of the resistance, to overcome the resistance, the pancreas will secrete more and more insulin. Hyperinsulinemia. So low basal insulin level false. Insulin level will be high. Low serum estrogen level.
False. Estrogen level is very high.
Yeah, estrogen level will increase because of the elevated androgen level. LH level elevated.
Because not only LH ratio, LH to FS
Ratio will change, but LH level elevate. Actually, we have to take it as false, but it might elevate it marginally above the normal range. But LH level elevated, it's not a feature, right? So we have to take it as false. Sex hormone binding globulin level is elevated.
True.
Decrease.
Sex hormone binding globulin level will come down. That's the reason we are having free androgen and androgenic side effect, all kind of things, isn't it? So sex hormone binding globulin level will reduce, not elevated. So they have mentioned sex hormone binding globulin level elevated, false, will reduce. Okay, any question? Really, you understood something? Any question? So in lean, oh, right. I about that. How to manage the lean body PCOS? Really sorry. Right. How are we going to manage the lean body PCOS? So in lean body PCOS, Are they obese? No. Are they having insulin resistant related pathology? No. Actually, they are having problem. They have elevated level of LH secretion. Second one, their ovaries are secreting more androgen. So your target of treatment is to inhibit the LH secretion and reduce the androgen secretion. Right? Inhibit the LH secretion and reduce the androgen secretion from the ovary. How can you reduce the LH secretion? How can you reduce the LH secretion? What you have to do? You have to suppress the pituitary. What is the drug which we are using to suppress the pituitary normally? That is your COCP. So if it is a lean body girl with PCOS, just give PCOS COCP for 6 months. That will suppress the LH secretion and their cycle will regularize. And the androgen level will, so androgen binding globulin level will increase and ultimately they will develop a normal cycle. So one is you can give COCP. If it is a subfertile woman with lean body PCOS, then what you can do simply, you can suppress, you can't give the OCP. The problem is if you give the OCP, it will further damage your subfertility part. So then what you can do, you can reduce the androgen production in the ovary. How can you reduce the androgen production in the ovary? We have discussed already. What you can do? You can do the ovarian drilling. Remove the theca cell. So ovarian drilling, and you can give the ovulation induction. So lean body PCOS, if it is a unmarried girl without subfertility, OCP will be the management. If it is a married girl with subfertility, then the management will be ovarian drilling and ovulation induction. That is how we are managing the lean body PCOS. What kind of situation we choose COCP? Yes, now I have told you. Lean body PCOS, unmarried, then OCP will be the answer. Any question? Okay, Tata. Any question?
Sir?
Yeah.
There was this stem where there was, it was saying LH, serum LH is elevated, but in lean body weight patients, LH will be
that's why I told you that is a controversial thing, right? Because if it is a lean body obese, the LH level will be will be elevated. So that's a kind of controversial thing actually, because majority 70% LH level will not be increased, maybe normal or marginal, but maybe small percentage we can have elevated LH. You're correct. Can't we use anti-androgenic drug in lean body cases? Of course, these anti-androgenic drugs are using for the symptomatic treatment, like hirsutism, acne. If you want to treat that, you can give anti-androgenic. Whether it's lean body, whether it's obese PCOS, no worries. We can give the anti-androgenic drug. But the anti-androgenic drug will not sort out entire problem. That will sort out only the androgenic effect only. Can clomiphene citrate given to randomly for PCOS girls because it can cause OHSS? It is like that. If I didn't touch more about that one, anyhow, the FSH and clomiphene has high risk to develop ovarian hyperstimulation syndrome. But still, the RCOG guideline, according to RCOG guideline and most of the clinical practices we are giving clomiphene citrate. So we can give, but there is a small risk of ovarian hyperstimulation syndrome as well as the multiple pregnancy. So that's why the first line treatment for PCOS woman as an ovulation induction is letrozole. because letrozole will stimulate only one follicle, monofollicular development. Right? Monofollicular development. So you can give it. You can give letrozole for PCOS woman. If there is an infertility for 1 year duration with high BMI without going for the weight reduction, can we go to the laparoscopic orientation? No. If it is 1 year duration, rather than going for a surgical measure, you have to go for a weight reduction and ovulation induction. If it is failing only, you have to go for a laparoscopic orientation. Actually, what is the easiest way to get hated by the woman? If Jessica want to hate me, I can tell one simple word, then she will easily hate me. What is the easiest way? Say you are obese, reduce your weight. That's it. So always we are having this problem when we are doing the practice as well as the hospitals. When we are saying, Amma, you have to reduce the weight, then you can see the expression of the woman. This bloody rascal don't know anything like that. Even they are getting angry too. But of course, you have to make them aware, because this woman has a kind of wrong concept, like because of the absence of menstruation, they are getting weight. Because the menses is not coming, that's why I'm getting weight. Now you will understand the pathophysiology of PCOS. What do you think? Why you are getting, is it correct because of the absence of menstruation, are you getting weight? No, right?
No, because
Yeah, it is other way around. Because of your obesity only, you are not getting the menses. Right? So because of the obesity only, you are not getting the menses. Yeah. Okay. Any question? If the woman without menstruation, they will depress. Is it a stimulation to menstruation? No. It's not a stimulation. Yeah. What did you ask?
The first SBA, why did you select cyproterone acetate instead of COCP? They both have androgen reducing.
No, the thing is COCP has second generation progesterone. That progesterone does not have anti-androgenic effect.
Oh.
But cyproterone acetate is a third generation progesterone which has anti-androgenic effect. That's why we select that one. So when you take OCP and cyproterone acetate has more androgen anti-androgenic activity.
Thank you.
Okay. Yeah. Okay then. So we had a nice time. So we will meet tomorrow with the theory session, and also next week also we will do some classes. Okay. Okay. Thank you.
thank you, sir. Good evening.
Okay. Good night.
Thank you.